All right, let me introduce myself. My name is Dr. Shaakir Hasan. I'm a radiation oncologist at the New York Proton Center. I've been asked by the ZERO Prostate Cancer Summit to give this talk on prostate cancer treatment options, and I am grateful to them for this opportunity and to speak to all of you. Just real quick, as far as disclosures, I have no financial disclosures. No one is paying me to give this talk. However, I will acknowledge that, as I said before, I am a practicing radiation oncologist. I do treat with protons, and I fully acknowledge that this might predispose me to have some type of biases. My training and my experience might predispose me to have some biases. However, I want to acknowledge that everything that I bring to you today, all the information I give, all the suggestions I might have, they are based on the best level of evidence and best data that we currently have available. So I just want to make that known. Okay, so as an introduction, I know the concept of this talk is to talk about treatment options, but I do want to have a brief introduction about the prostate gland itself, kind of the basic anatomy, because it does give us a nice framework as to what to expect when it comes to side effects for the different types of treatments you have available to you. So the prostate gland, anatomically, where is it located? It is an organ that is under the bladder. The bladder is here, and it's in front of the rectum, which is here, and it's on top of the penis. So you see it kind of centrally in the pelvis, this structure right here. One important component of this entire genitourinary pathway is the urethra. So the urethra is a tube that empties the bladder, and it goes through the penis, but it also goes right through the prostate gland. This is important to note because this is kind of the centerpiece. It's one of the main reasons why you might have certain side effects given different prostate cancer treatments. So what does the prostate gland do? Why is it there? The primary role is to help with fertility. So the gland itself actually secretes nutrients into the seminal fluid to promote healthy sperm during procreation. Otherwise, and this is important, it's not essential for life or any other function. This includes sex, this includes urination. It's just not a necessary component. So after procreation, after men, or you're done having children, effectively the prostate gland becomes expendable, and that's why you can remove it if there's cancer in it or radiate it safely. Okay, so now let's talk about prostate cancer itself. Taken as a whole, prostate cancer actually has a very good prognosis. This is in comparison to a lot of other scary cancers, brain cancer, pancreatic cancer, lung cancer, things like that. Prostate cancer has a relatively good prognosis. The vast majority of patients are either cured or do not die of their cancer. That's important to note. However, there is a wide range of outcomes. So prostate cancer can be anything from having zero impact at all on your survival, your quality of life, or it can actually cause death within a couple of years if you have really bad disease. Now, the latter is a lot more rare than the former, but it is still important to know what you have, and it's really important to detect it early and then gather all the information necessary to determine exactly what risk category you are in, and from there, what your treatment options are. So speaking of the risk categories, and I will refer to these risk categories throughout the talk because, again, it really determines what options there are available to you. So it is important to spend a little bit of time to really understand what these risk categories are, where you might fall into them. We have very low/low risk. We have favorable intermediate risk, unfavorable intermediate risk, high risk or very high risk, and metastatic. Now, what are the components that goes into these risk groups? This is also something very important to learn, and this is the information gathering that I was talking about. So once you have your diagnosis, you want to get these other components as well, starting with the Gleason score. So the Gleason score is after you get your biopsy and these cells are sampled and they're looked under the microscope by a pathologist. This tells us the intrinsic aggressiveness of the cancer itself. So it says nothing about the extent of the cancer or how advanced the cancer is, but it gives us kind of the nature of the cancer, the nature of the tumor cells and how they are likely to behave. This has been shown to be the most important driver of prognosis. The PSA, which I'm sure you're all familiar with, this is a blood test. This is something that you get. It's a protein that's emitted by prostate cells and prostate cancer cells. So it's a surrogate for how much volume of cancer there is, but it is an imperfect measure. Okay, so it's not the only thing we look at, but it does help us to know, especially once you've had prostate cancer and it's established, it gives us an idea of how much prostate cancer is in your system. The T stage, this can be determined by a physical exam or an MRI, which is a type of imaging. This tells us how locally advanced the cancer is. So does the prostate cancer stay within one lobe of the gland? Does it spread to the other lobe? Does it go to the capsule? Does it go beyond the capsule? Does it invade the seminal vesicles, etc.? This tells us the local extension of where the prostate gland is. And then you also want to rule out that it's not distant. It has not spread beyond the prostate gland to your lymph nodes or to your bones or other organs of the body. That's what we call metastatic disease. And so you can determine this with a bone scan. Sometimes a CT or a PET scan is indicated as well. And you want to just make sure that when you're dealing with prostate cancer, you know exactly if it's still localized or if it's spread. And for the vast majority of this talk, we're going to be discussing options if it's still localized or at least locally advanced. So this is a busy slide. If you look on the left, you will see all the risk categories that I mentioned previously. And then on the right, you have several treatment options, including surgery and several types of radiation therapy. Now, on the left, I also did, it's beyond the scope to get into the specifics of the Gleason score and the PSA scores and the T staging. I did list typically what you're going to see for each group, a Gleason 6 for very low, for example, and then a Gleason 4 + 3 = 7 for unfavorable intermediate. Again, the actual pathology is beyond the scope of this talk, but just know once you gather this information and you can determine what risk category you're in, from there we can talk about the different treatment options that are available to you. Of note, I want to state that everything listed on the right here, these are approved by the NCCN, by the AUA, by ASTRO, by ASCO. These are all the large cancer organizations from urology, radiation oncology, medical oncology that have come together to have recommended standards of care for these types of for the prognosis group of your prostate cancer. Notice that there are going to be some things such as HIFU, cryotherapy, that are not mentioned in this talk. You can go elsewhere, more like a urologist discussion to look into those. There's also natural remedies that people will use. I'm not talking about those because they have been proven to be not as successful, and they are not recommended by kind of the powers that be in oncology. So I'm going to focus on what's considered standards of care. With that said, there are plenty of standards of care per given for prostate cancer. So there's still kind of a lot of options for you. So starting with the very low or low risk group, the treatment of choice actually is to not do any treatment at all. It's what we call active surveillance. So I'll get into that a little bit more into that on the next slide. But once you get into favorable intermediate, okay, now the playbook is kind of wide open. Now you're talking about surgery in addition to different types of radiation, including brachytherapy, Cyberknife, protons, or MRT. And then once you get to the unfavorable intermediate group, now you're talking about combining a couple of these modalities or just do surgery. You're talking about introducing anti-hormone therapy, which is a systemic therapy. Once you get into very high risk, you still have surgery as an option, or now you're combining anti-hormone therapy with various types of radiation. And once you get to metastatic disease, again, this is when it's spread beyond the prostate gland. You're typically looking at just anti-hormone therapy alone. You're kind of removing the local therapy components from it, meaning surgery or radiation. But for select patients, you can actually offer radiation as well. So I know this is a really busy slide and there's a lot more depth to get into, and I'll try to break these down in the slides coming up. But this is kind of a summary, starting point, looking again at what risk category you're in and then what your treatment options are that are available. Okay, active surveillance. So does that really mean do nothing? Not quite. It's true that you're not taking on an intervention. You're not doing any type of radiation or surgery at this point, but active surveillance does require that you have routine PSA testing, routine rectal exams, routine imaging like an MRI, and occasionally a repeat biopsy. So half the patients in this treatment option with low risk disease who say, hey, I want to just watch it for now. I don't want to do anything. I'll see if it gets worse. Half the time it does get worse. Okay. And those patients, when the disease progresses for whatever reason, they will end up getting treated. The important thing to note, though, is that those patients that do delay their treatment, they don't do any worse than those that were treated from the very beginning. There's no change in survival, no change in ultimate cure rate. So therefore, there's nothing, you really don't lose anything by waiting if you're in that risk, if you're in that low risk category. And then, of course, there's another half of those patients who never have to get anything. So they actually get away with just watching and monitoring their disease for their entire life. So for that reason, this is the preferred management for low risk disease. Now I'm going to jump ahead and skip all those risk groups in the middle for right now, the intermediate risk group and the high risk group, because I wanted to touch on metastatic disease really quickly. Classically, metastatic disease has only been treated with systemic therapy, meaning the anti-hormone therapy, sometimes chemotherapy. But now, very recently, in the past couple of years, there's been pretty strong evidence, as per the STEM-P trial, to suggest that some patients with metastatic disease, those with low burden metastatic disease, meaning a few sites of disease in the bone, they can actually live longer with a combination of radiotherapy and systemic therapy. And that's going to be either IMRT, Cyberknife, or Proton therapy. This data is relatively new, and not all urologists and medical oncologists, or even radiation oncologists for that matter, are going to be aware of it. So I just want to note that if you have been diagnosed with metastatic prostate cancer, you're probably told that there's no role for local therapy. It does not hurt to at least inquire about the role of radiation in this situation, because there are some patients that can benefit and can actually live longer with the combination of systemic therapy and radiotherapy. Okay, so now let's switch gears and talk about the options available, again, for those intermediate and high risk groups, and start with surgery. Again, I want to say here that I am not a urologist, and so I'm going to be talking about the classic radical prostatectomy. There are some other variations of prostatectomies, whether they're laparoscopic or robotic, whether there's nerve sparing or not. I'm going to be talking more in general terms, and I am going to be using the best available data, the best evidence we have when comparing these modalities to radiation. So the prostatectomy, it's a surgical procedure that involves removing the prostate gland, the seminal vesicles, and also removing the urethra that goes between the bladder and the end of the penis here. And you're removing this whole structure here. This is, again, the prostate gland and the seminal vesicles. And then you have to reattach, reanastomose, reconnect the urethra that is still remaining. So this can be performed for all localized prostate cancers, meaning from low risk to intermediate risk to very high risk. However, it is important to note that in high risk patients, particularly very high risk patients, anywhere from a third to a half of those patients do require additional treatment, because it's really hard to get the entire gland to get everything and not leave any disease behind. So there's about a 33 to 50% chance of those patients to recur in high-risk disease. Although because of that, because of the ability to still avoid treatments and still cure you with about 50% rate, it's still a standard of care for high-risk disease. So it's still a good option there. So what are the pros of surgery? One thing is you get to learn the exact pathology. You know exactly what you're dealing with your prostate cancer. So when you get a biopsy, remember, a biopsy is a random sampling. Now it's not so random anymore, because now we're doing MRIs and finding the lesions and targeting them, and that's helping. But you're still not getting the entire story, because you're only getting parts of the prostate gland. And for the most part, this still works very well. 95% of the time, you know exactly what you're dealing with as far as a Gleason score, and you can treat appropriately. But there is, on those occasions, at 5 to 10% of the time, where you might be missing more aggressive disease, and therefore you might not be treating properly because you don't have the full information. So when you get a prostatectomy, you can remove the entire prostate gland, you can slice up the entire gland and see exactly what you're dealing with, and you know, therefore, what your true prognosis is, and if you might or might not need any additional therapy. You can also, as I mentioned before, avoid radiation and anti-hormone therapy. I'll talk about anti-hormone therapy and radiation and the side effects there and what you might be dealing with that. But if you really have it in your head that you want to avoid those at all costs, then surgery is a way to never having to deal with those potential side effects. Again, I want to note that there are a lot of cases, particularly with high-risk disease, where you're not going to get all the disease, and so you might have to get those therapies anyway, but you at least have an opportunity to avoid them. One of the other pros, and this is what I actually think is probably the strongest indication, in my opinion, to get surgery for prostate cancer, is it should help the obstructive symptoms if they are already present. So beyond the scope of this talk to talk about an enlarged prostate gland or benign prostatic hyperplasia, but many, many men have this, in addition to prostate cancer, they have an enlarged prostate. They can have what we call obstructive uropathy, meaning that there are cells that are kind of impinging on the urethra and causing a weak stream, incomplete voiding, just these symptoms that are making it difficult for you to urinate. And if you have those at baseline, if you're really uncomfortable at baseline, you have a tough time, really the best way to relieve those symptoms, even with prostate cancer, is to remove the gland entirely, remove the obstruction entirely, and then kind of reconnect the urethra and kind of relearn this new anatomy. Whereas radiation or some other types of therapy, it might cure the prostate cancer, but it's not going to do anything for that mechanical obstruction. So a lot of my patients that see me, treat the vast majority of them, but if they come in with obstructive uropathy, I will oftentimes refer to urologists to say, hey, Radiation can make that worse. It probably won't make it any better. And then the last thing is that if the prostate cancer were to come back or was not completely removed, it is easier to treat again with other therapies such as radiation, as opposed to vice versa. It's difficult to do surgery or remove the prostate gland after you've already received radiation. What are the cons? What are the drawbacks? So you have at least typically 6 weeks of recovery and trying to relearn this new anatomy, because again, you're creating new anatomy after the surgery. So there's a good 6 weeks of pretty much total incontinence and learning how to gain your urinary function back. But then even long term, there's about a 1 in 5 chance of maintaining urinary incontinence. Now that doesn't mean that you have complete loss of control, that no one would do it if you had a 20% rate of no one being able to urinate again. But it does mean that you might have to deal with some leakage. You might have to wear pads or condom catheters, things like that, that it's kind of up to the patient to decide, is this a side effect that I can live with, or is this going to be really bothersome? It's kind of, it's up to the patient. It depends on what your perspective is. And as far as erectile preservation or erectile dysfunction, there is a pretty high rate, amongst all the different therapies mentioned here. The highest rate of erectile dysfunction does come with radical prostatectomy. It happens in about 3 in 4 men. Okay, so now that was a little bit on surgery. I want to talk about radiation. The slide earlier mentioned several types of radiation, and I know it can be really confusing, so I'll try to break it down a little bit and simplify it a bit. So there's 2 main categories of radiation. One is called external beam radiation, one is internal radiation. So external beam radiation kind of means, just as it says, there is a machine that is outside of the target, which is the person with the prostate gland, and it shoots radiation, X-rays, photons, or protons in some cases, from the machine to the target. So it's external, it's going towards you. Whereas internal radiation, this is where you implant radioactive seeds, little tiny seeds that go into the prostate gland, and they emit radiation outwards. Okay, so the external is coming from the outside going in, the internal radiation is coming from the inside going out. So within the external beam radiation, you have kind of your classic conventional or IMRT radiotherapy. This is widely available, probably within 10, 20 minutes or wherever you are, you can find a clinic with IMRT capabilities. Then you get a little bit more advanced, a little bit better targeting, a little bit more precise with Cyberknife or SBRT. This is basically doing the same type of treatment, but in 5 fractions. And then you have proton therapy, which is another type of external beam radiation. Instead of emitting photons or X-rays, it's emitting protons. And there are some different physical properties, namely the fact that there is no exit dose with proton therapy. And I'll get into that a little bit more on a later slide. Going back to internal radiation, and I'll have this on the next slide, let's talk about that for a second before we get into external beam radiation. So brachytherapy is another term for the internal radiation, which again are radioactive seeds that are implanted into the prostate gland. This is a 1-day procedure. You are asleep for this. It's under anesthesia. The radiation oncologist will use this ultrasound rectal probe right here to visualize the prostate gland, and then use needles to evenly distribute these little pellets, these radioactive pellets that are about the size of a grain of rice, about 5 millimeters apart, and evenly distribute them all throughout the prostate gland. This is nice because you actually get a really, really high dose of radiation that's confined to the prostate gland. It's not going to go anywhere else. You'll have some bladder, some rectum, but really for the most part, it's confined within the prostate gland. So what are the pros? It's a one-time procedure. You go home the same day. You don't have to recover in the hospital, and there's pretty minimal recovery. It's unlike the 6 weeks you have with surgery. There's less overall dose to the entire body, meaning radiation dose to the entire body compared to external beam radiation, but you actually get a higher dose to the tumors. So this is what we call a therapeutic ratio, and you have kind of the greatest therapeutic ratio with brachytherapy. There's going to be less gastrointestinal toxicity and erectile dysfunction compared to IMRT, conventional radiation or surgery. And that's because, again, you're confining the radiation to the prostate gland. And then oftentimes it can be combined with external radiation to improve cure rates in higher risk disease. So again, this is because you're getting that additional dose compared to external beam radiation. So for higher risk disease, you might want to do that because they're more aggressive. What are the drawbacks though? So there is a considerably higher rate of acute burning, urgency, frequency for the first couple months, and then that does tend to subside after a while. But long-term, approximately 20% of patients, that's 1 in 5 patients, do have long-term urinary symptoms, typically stemming from a narrowing of the urethra, and that turns into obstructive uropathy. So this is like weak stream, incomplete voiding, waking up at night several times, intermittency and dribbling. This can all happen as a result of brachytherapy, because even though you're getting that very high dose to the prostate gland and you are avoiding all these other structures, rectum, bladder, etc. Again, as I mentioned before, the urethra goes right through the prostate gland, and it's really difficult to avoid getting that high dose to the urethra itself. And obviously, clinicians will try that, and sometimes it's more successful. But in order to really get that the distribution correctly, it's going to be really difficult to avoid the urethra completely, and that's why 1 in 5 men do have long-term urinary issues with brachytherapy. Okay. So conventional photons, or IMRT, this is again what's pretty ubiquitous across the country. You can find this and access this in many different clinics. You're emitting X-rays or photons, these are the same thing, generated by a machine. This is what we call a gantry, and it's pointed towards the prostate gland. So again, this is external beam radiation. This is offered for all risk groups, sometimes in combination with other treatments, as we mentioned. So what are the benefits of conventional or classic IMRT? This is really well studied, and the treatment itself is completely painless. There's no invasive component to this. It's tolerated very well for a long time as far as acute and long-term side effects. And like I mentioned, the treatment is very accessible. So what are the cons? Some places can be very inconvenient. Some places are still treating as many as 44 fractions. Most of this has been coming down now to the mid-20s. So that means you get treated 20 sometimes, 26, 28 times, as opposed to 44. But that's still, several times going back and forth, 5 days a week for several weeks. The erectile dysfunction rate is better than surgery, but it's still about 50-50. It's still not great compared to other possible modalities out there. And one of the big differences between photons and protons, which I'll get into a little bit more, is that you're still spilling a low and intermediate dose of radiation throughout the pelvis. And that means that there's going to be more radiation delivered to the bowel, to the bladder, which can possibly give you long-term toxicity and secondary cancers. So let's talk about Cyberknife, or Photon SBRT, or Cyberknife. This is the same thing. The concept is the exact same. There's still a machine that's rotating around the patient, and it's still targeting the prostate gland. However, the targeting is a little bit better. The delineation of the prostate gland is more precise, so you're able to give more dose per treatment. You quote unquote pack a stronger punch. You can deliver the treatment in just 5 sessions, sometimes even less than that. And when you give more dose in each session, you're kind of increasing what we call the biologic dose, or like the effective dose. And we think that might give us higher rates of cure. That hasn't borne out just yet. We do know that there are slightly higher rates of acute and late urinary side effects. Nothing too major, but patients do often like to trade off the convenience of 5 treatments, and they'll accept a little bit higher side effect rate, but that has been known. Right now, this has been acceptable for low and favorable intermediate risk disease. Anything else, such as unfavorable intermediate risk or high risk, it's still considered experimental. There are many clinical trials, including one that we have ourselves, and that are testing this for different risk groups. But right now, it's acceptable for low and favorable intermediate risk. One thing I will note, although you have that precise targeting with Cyberknife and SBRT, you still have that intermediate and low dose spillage. So the amount of radiation that's still going around the bladder and the rectum and the bowel and all that, it's still going to be there. However, you can condense the treatments in 5 fractions. In the proton world, which again, I'll get into a little bit more detail in the next few slides, you don't see SBRT programs too prevalently throughout the country. The New York Proton Center does have a proton-based SBRT program, so this is kind of combining the benefits of Cyberknife or SBRT with the benefits of proton therapy, and we are currently enrolling. So you're kind of getting a combination there, but that's not typically done. This is something that you have to kind of seek out. So let's good segue for what proton therapy is. As you can see, it's quite similar. You still see a gantry. It's a little bit bigger and still rotating around a table where there will be a patient. You still have to build up radiation to get to the target, but unlike photons or X-rays, there is no exit dose. So it just goes to the prostate gland and it just stops right there. Whereas photons or X-rays are going to go to the prostate gland and then start to dissipate on their way out. And so as a result of this, you end up getting much less total radiation to your body, about 30 to 50% less total radiation to your pelvis, to your entire body, but there's still the same amount of radiation to the prostate gland itself. And so this is illustrated here on this diagram. These are pictures of a treatment plan. And so if you look on the left, you have treatments with protons, and if you look on the right, you have treatment with IMRT, conventional radiation, and also the same principles with SBRT. So if you see here, this is an axial slice, meaning kind of for slicing you as if you were a loaf of bread. This is the prostate gland, and then you have to the side, radiation beams are coming through and getting radiation to the target, which is the prostate gland. As you can see, there's nothing in front of it, no radiation behind it, whereas with IMRT or conventional radiation, you're kind of hitting it from all angles. You have to do this in order to get the amount of radiation that you need to the target, and then you're kind of spilling all this dose everywhere. Same thing if we had to treat lymph nodes, because sometimes we have to treat beyond the prostate gland and collect lymph nodes in higher risk disease. Same principle, you have some radiation coming behind and from the sides with protons, but you are completely sparing everything in between the nodes, which is the small bowel, which is very sensitive to radiation, and the rectum behind it, that's getting pretty much no dose at all. Whereas with conventional therapies, again, IMRT or SBRT, you are still getting this spillage, this intermediate dose range that's still affecting the entire bowel and rectum. And then if we had lower slices, we'd see the bladder, it would have the same effect. So what are the pros? The dosimetry that I just went over, as I mentioned, it helps spare the bowel, the bladder, and the genitals more so than conventional radiation. So that lowers the risk of secondary cancers that might develop from this dose spillage, and then also presumably long-term toxicity, as again, you're getting less radiation to these organs. Among the published data right now, the cure rates are higher and toxicity rates are lower compared to historical IMRT numbers with proton therapy. However, and I want to make sure that this is known, and I am a physician that treats the proton therapy, but I'll acknowledge that there's been no head-to-head comparison thus far, no randomized data to suggest that this difference in dose does translate to a difference in side effect. We believe that it does, and it does make sense, but we still have to wait for this data to come out. We're working on collecting it, but we're working on getting this data to really present it and kind of state this as a fact. Right now, it just makes sense clinically and theoretically, but we still have to wait for the data to come out. And what are the drawbacks? So really the biggest drawback I would say with proton therapy is accessibility. Unless you have Medicare, insurance companies are much less likely to cover proton therapy just because it is more expensive. And proton centers, as I mentioned, are less accessible. For example, the New York Proton Center is the only one in the state of New York. And there's approximately 30 or so proton centers in the country. That's compared to about 5,000 or so radiation oncology clinics in general in the country. So it's a lot more rare and more difficult to find. Okay, and I do have a couple of slides kind of comparing everything because I know that we went over a lot. But before I get into these specific radiation differences and surgery differences, I do want to make sure I touch upon androgen deprivation therapy. You might hear this referred to as ADT or anti-hormone therapy. The whole point here is to cut off testosterone, is to reduce the amount of testosterone in your body, because testosterone effectively feeds prostate cancer cells. And the treatment of choice, if the prostate cancer were to spread beyond the prostate gland and go to your bones, what we call metastatic disease, the treatment of choice would actually be just ADT, anti-hormone therapy, because it's that effective in kind of eliminating this quote unquote, food source or sustenance source for the prostate cancer cells, and they end up dying out. It's also very effective and a lot of times necessary to be used in conjunction with the radiotherapy to treat higher risk disease. This is typically given as a shot that lasts 1 to 3 months. You can have it from anywhere from 4 months to 36 months. Typically for unfavorable intermediate risk disease, it's given for 6 months. And then for high risk, it's given for 18 months. Very, very high risk, you might have it for a little bit longer. I also want to note, since I think I wrote this, gave this talk a year ago, since then, they have developed a pill that you can also have ADT in a pill form. And a lot of patients do prefer this just because they have a little bit more control over the ADT. Side effects, they're not too fun. They include hot flashes, decreased libido, joint pain, fatigue, long-term osteoporosis, and can predispose you to heart disease. With the exception of osteoporosis and heart disease, a lot of these symptoms are not dangerous. They don't really have implications as to survival and things like that, but they are quite annoying. And it is a common complaint that we get with patients that do get ADT. But it is important to note that it's not debilitating, it's not dangerous or life-threatening. If you are a patient that does have a history of heart disease, you have a history of heart attacks, then it's something we definitely do consider and reconsider giving because we're worried about that in the future. But the vast majority of patients are healthy enough to get ADT successfully. As I mentioned before, one of the benefits of surgery in localized high-risk disease is the ability, the potential opportunity to avoid getting ADT and avoid these side effects. Again, I want to mention in high-risk disease, though, there's a 30 to 50% chance that you are going to be missing, not able to remove all the disease, and you'll need it anyways, but it still gives you some opportunity. Okay, so let's broadly speaking talk about the differences between surgery and radiation. I'm not going to break down the different types of radiation here, but just broadly speaking, looking at surgery versus radiation. So historically, the thought has always been that younger, healthier patients receive surgery over radiation because they can recover quicker as younger people. And also there's a presumed quote unquote later effect, late side effects with radiation that can happen many years down the road, decades down the road. So if you're in your 50s, you might be fine for the first 10 years with radiation, but then what happens later? That's been the conventional thought, but there's been no evidence to really support this. There's been no papers to really support the idea that down the road, you're any worse off as far as symptoms or side effects with radiation than you are with surgery. There is a small but real chance of a secondary cancer that you can get with radiation that you don't get with surgery. Because again, if you're introducing radiation to your body, that always does predispose you to having a secondary malignancy. However, it is exceedingly rare. It's about 1 in 1,000 with conventional radiation and maybe 1 in 4,000 if you do protons or brachytherapy. So really what it comes down to is there's no difference in cure rate. This is the most important thing. There's no difference in cure rate or metastasis-free survival, meaning the opportunity for the cancer cells to spread and get beyond the gland. There's no difference between surgery and types of radiation in general. So it comes down to, what side effects are you willing to risk? What quality of life are you looking for? So with surgery, the acute incontinence rate, this is right after surgery, and the recovery period is about 50%, if not higher. Long-term incontinence, like I mentioned before, is about 1 in 5 men. Erectile dysfunction is about 3 in 4 men. And then surgical complications are rare, but non-zero. Anytime you go to the operating room, there is a risk of bleeding, of perforation, of things like that. So that's something to consider as well. With external radiation, notice with surgery, you don't have any gastrointestinal issues because they can move all the bowel, the rectum out of the way. So that's typically not a problem. With radiation, you can't do that quite as well. So diarrhea is a 5% rate. There's a long-term rectal bleeding rate of about 3%. Erectile dysfunction is better than surgery, but it's still not great. It can be anywhere from 30% if you're doing brachytherapy or protons, or up to 50% if you're doing conventional radiation. About 1 in 3 patients are going to have some type of acute urgency frequency during treatment. The vast majority of them recover afterwards, but during treatment, you will likely to experience that. Secondary cancers, as I mentioned, exceedingly rare, but non-zero. And if you're dealing with a population of millions of people getting prostate cancer, getting treated, there are going to be a few people that do develop secondary cancers with radiation. And then lastly, the ADT side effects, if necessary, again, you have to deal with those as well for higher risk disease. Okay, and one thing I want to mention, this slide is also very busy. I wanted to try to compare different parameters, looking at the individual radiation types and compare them to surgery. One thing I do want to mention here, there's a caveat here. This slide is kind of based on the best available data, but we don't have high-level randomized evidence to compare radiation modalities, at least not yet, as I mentioned earlier. We do, however, have really strong data comparing radiation, particularly classic radiation, with surgery. And that's why all the factoids I mentioned before in this slide, very confident about. We can say this is a fact just because we have strong randomized evidence to compare the two. We do not yet have strong randomized evidence to compare the different types of radiation. I won't go through every single parameter here, but I just kind of want to highlight each type of treatment and kind of the overall pros and cons. With brachytherapy, what you're really getting, the real advantage there, in addition to the convenience of just kind of coming in one day and being done, is that you really get a high dose of the prostate gland, more so than protons or Cyberknife or anything else. And so you kind of really advance this therapeutic ratio. However, it's really, really difficult to control the dose and spare the urethra. And, me personally, my personal opinion is that in most cases, I kind of preserve brachytherapy for those patients that have really advanced disease, a high Gleason score, like a Gleason 9, something that I think really needs that extra radiation dose that you can't quite get with external beam radiation. And in those cases, because it's such aggressive disease, I think it's worth the risk of additional urinary toxicity, long-term urinary toxicity with that additional dose to the urethra. Otherwise, I think with more favorable risk disease, unfavorable, or even just kind of a middle of the road, high risk disease, I don't think it's quite worth it personally to incur that late toxicity risk. But I think if you have quite aggressive disease, then it is something that you should strongly consider. IMRT, conventional radiation, is still a very, very good therapy. It's very accessible. We have a lot of strong data with it. And it probably does offer the best, especially if you're spreading the treatment out over several weeks. It probably does offer the best as far as your cure rates when it comes to side effects. However, you still have this concept of collateral damage, as I mentioned before. You're still spreading this dose throughout the pelvis, and you're getting more dose to the bladder and to the rectum relative to protons. And so presumably your side effect profile is going to be quite as good as you would get with protons. Cyberknife or SBRT, the real benefit here is the convenience factor. I mean, you get really precise targeting, but you also get this treatment done in 5 treatments. You can do this in 1 week or 2 weeks, depending on if they treat you daily or every other day. And so it's a really, really good treatment as well. We're seeing it more and more frequently. We're in the proton world, even adapting it so that we're also treating patients with 5 fractions as well. So this is a very convenient treatment. We should note that recent studies have shown that the long-term urinary side effects are slightly worse. That's why it's 1 check compared to 2 checks than if you were to spread the treatment out longer. But for the most part, it's still very, very well tolerated. And a lot of patients love this treatment just because of the amount of fractions. Protons, I talked about pretty extensively. The major difference, again, as I'm going to say one more time, is just you're getting less dose to the bladder, less dose to the rectum, less dose to the small bowel, and all these sensitive organs around your pelvis, particularly in patients that are going to live a long time because prostate cancer is quite curable. I do think that is something that's important to consider. You want to minimize the amount of radiation you get to the rest of your body if you can still have a very high cure rate. And just to note that concept is not as good with protons as it is with brachytherapy. The big difference, though, is with brachytherapy, you cannot control that dose of the urethra quite as well as you can with protons. And so you don't have this risk of long-term urinary toxicity with protons like you do with brachytherapy. And then with surgery, I think I kind of highlighted it mostly on the previous slide. But the biggest discrepancies here are just the overall invasiveness of it. So when you remove the anatomy, when you remove the prostate gland, you have to relearn it. So this risk of long-term urinary incontinence, albeit it may not severe, it is real. But again, you do possibly have the ability to avoid radiation side effects if you can clear all the disease, to avoid ADT if you can clear all the disease, and you get to know exactly what you're dealing with when you remove the prostate gland. One important thing to note, you see at the very top, the cure rate, the rate of overall survival, and the prevention of metastasis is going to be the same amongst all the modalities. That is the most important thing. So once you're beyond the cure rate, again, you want to think about convenience and side effects and what treatment might be best for you. Okay, so in summary, just to kind of wrap things up, I will say that you will likely have several great options available to you to treat your prostate cancer. And this is a good thing. I want you to be happy about this. If you're diagnosed with prostate cancer and you feel a little overwhelmed with all the decision-making process, it's actually really good to know that you have options. So while the information might be overwhelming and the decision process may be daunting, it's hard to make a wrong decision. You have several good options. You might think one is better than the other. You might think there's an optimal one, but really you have several good ones available to you. Sometimes the best treatment option is the one that coincides with the factors that are most important to you. So, is it erectile function? Is it urinary toxicity? If you have a history of GI problems, are you really worried about rectal dose? Or is it just convenience? Do you not have the time? Do you have to get this done in one treatment? Do you only have 5, can you only get 5 sessions? Are you unable to go a full 6-week course of radiation treatment? Are you unable to go a 6-week period of recovery from removing it? Everybody's different. So this is something that you want to consider. But one thing that I will implore you is, regardless of what you choose, please consult with several physicians who offer the aforementioned treatments, so you can be the most informed prior to making your decision. So don't let me, the radiation oncologist, give you all the details about surgery. I simply don't know them. Don't let a urologist tell you about radiation therapy. Don't let a brachytherapist tell you about proton therapy, et cetera, et cetera. I very much encourage you to do this quote unquote doctor shopping and really seek out the best treatments and see what you're most comfortable with, see what physician you're comfortable with, try to weigh the pros and cons of all the different options, and you can make the best decision for you. But again, I do want to emphasize, it's really difficult to make the wrong decision. There's going to be plenty of great options out there for you. So I do want to mention, lastly, if you have any questions at all, I'm very happy to respond. I'm very accessible by email. It's shasan@nyproton.com. If you want to inquire about proton therapy, you can call our center at 833-NY-PROTON. I very much appreciate your attention, and I know there's plenty that we didn't cover as well, and I'm always available and happy to take any questions. So thank you very much.